This morning, I am joined by Leo Cuello. Leo is a research professor at the Center for Children and Families at the McCourt School of Public Policy, and this is at Georgetown University. I got to hear Leo speak early April of this year at the Disability Policy Seminar. Leo, I'm a physical therapist by training, and I thought I knew about Medicaid until I listened to you talk. So, just first of all, good morning. And second of all, thank you so much for being here.
Thanks so much for having me on the podcast. I'm really excited to be on it and to talk to you about Medicaid, which I love a lot and I can talk about a lot. So your job will be to rein me in to stop me when I just keep going and going. But I'm excited to talk to you about Medicaid today.
To kick it off, Leo, can you let the listeners know what actually is Medicaid? Just generally, and then specifically whittle down how does Medicaid affect the disability community, and what are the services that it covers?
Okay, so there's a lot in there, and let's start talking about this program. It is very complex, and so there are all of these families who have individuals enrolled in Medicaid and struggle to understand the program they're enrolled in. Um, Medicaid is the nation's largest health coverage program, right? This program is covering nearly 80 million people. That's 73 million directly covered by Medicaid, and then another 7 million that are covered through the Children's Health Insurance Program. But most of those kids are also getting the same Medicaid benefit. So between Medicaid and sort of its little sister, the Children's Health Insurance Program, which you may hear people call CHIP, um, they're covering nearly 80 million people. That's more than 1 in 5 people in this country. And I always like to put that into perspective. We have this Medicare program out there covering people with disabilities and seniors, and it's a great program, and we hear so much about it, and everyone loves it so much, including me. Um, but it's only covering 50 to 60 million people, depending on how you count it. That's 20 to 30 million smaller than Medicaid. Yet you don't hear much about Medicaid. So Medicaid is this powerhouse out there getting comprehensive health insurance to so many people, and it really doesn't get a lot of attention. So that's the first part of the story. But the second part of the story is even more important in some ways. 80 million is, of course, a very big number. And that's a big deal, right? This is the health insurance of 80 million people. But you also have to look at the roles Medicaid is playing for the system. Medicaid is covering an incredibly wide range of people, nearly half of all children, covering pregnant women and paying for nearly half of all births. Just think about that right there. Half of the births in the United States, half of the kids in the United States, right? It's astounding we don't talk more about this program. In addition, Medicaid is covering low-income parents, it's covering older adults. In the 40 states that have expanded Medicaid, it's covering adults more broadly. And of course, Medicaid is critical to people with disabilities, right? And um, that leads us to this other really amazing role Medicaid is playing, which is this long-term care role. So should we go into that a little?
Please, yes.
So this is, I would say, the most important, least under, at least understood thing about the Medicaid program. If I were to stop a random passerby on the street and ask them, hey, what happens, let's say, to a senior citizen that can no longer live safely home alone? Because maybe they can't bathe themselves or they can't get dressed or whatever the case may be. Most people would say, well, they probably would go to a nursing home. And if I said, well, what happens if they can't afford the nursing home? They would probably say, well, I guess Medicare must pay for that. And that's wrong. Most people don't understand how this works. So let's be really clear. In the United States, first of all, we actually don't have an official long-term care program. Right? So this is a huge gap in our system as a country. Instead, it is the Medicaid program that steps in and is paying for nursing homes or other long-term care relied on by people with disabilities. And there's actually two important points to make here. The first is that Medicaid is paying for 60%, over half of the long-term care in this country. So just think about that. 60% of the nursing home care or intermediate care facilities for intellectual disabilities, that's Medicaid, right? So I always tell people, I literally can't imagine the United States, right, without this Medicaid program doing what it's doing. But for people with disabilities, one of the things that we really care about um, is this second point, which is that this Medicaid program has pioneered and really led the growth of access to home and community-based long-term care. Medicaid is funding about 70% of the home and community-based services in this country. So Medicaid is at the cutting edge. It's pushing the system to finance more and more dollars through home and community-based settings, support services for families, paving the way for people with all kinds of disabilities and others who need supports to have, right, maximum independence, maximum health, staying in their home and community, right? And so this in turn is allowing people with disabilities to be close to their families. It's allowing families to keep their loved ones with them in the community. And, I always say it also allows the communities to benefit from the skills and contributions and wisdom of people with disabilities of all ages that are out there, right? When we take people with disabilities and we force them out into, some facility in the middle of nowhere to get their health care, that's really bad for them, but also our community, which loses those people. So, you know, in like to put this together, right? Medicaid is the health insurance of 80 million people, but it's really so, so much more. And you just think about all of this, 70% of the home and community-based services, um, 50% of all births, 50% of all kids. And you have to ask yourself, right, why would anyone ever think of getting into cutting this program?
Leo, I just want to quickly clarify that Medicaid, like in Tennessee, is known as 10K. So I just want to kind of put that out there. And when you talk about home and community-based services, it's covered through ECF choices in our community. So I just wanted to kind of let the listeners know about that. But circling back to how is Medicaid actually funded, Leo? It's such a I mean, I need for you to give our listeners an idea of how this works. How does the
Yeah.
money flow?
Let's let's get into funding, but you raised a really important point there about the name of Medicaid in Tennessee, right? TennCare. And let's talk about why that is so that your listeners in Tennessee and also out of the state can understand a little bit about how the eligibility for the program works, because that will give the context for a lot of the issues around funding. Um, Medicaid eligibility is phenomenally complex. I mean, I feel like I could teach a course on Medicaid eligibility and have enough to cover a full semester. Um, but let's hit on two really important points about how the eligibility works. First of all, every state has options in terms of how it structures its Medicaid program. They have mandatory populations that they have to cover, and then they have optional populations that they can choose whether they cover or not. And so the significance of that is that every state comes in and sets up their state Medicaid program a little differently. They all have to cover the mandatory services, but then they have this menu, sorry, mandatory populations, but then they have this menu of optional populations that they can choose to cover. And that's why if you're in Tennessee and you're in your Tennessee TennCare program and you have a conversation with somebody in Florida or in Michigan or any other state, there might be some people that are eligible in Tennessee that are not eligible in Florida, and there might be people in Florida who are not eligible in Tennessee because Tennessee has set up some optional programs, right? A, B, C, and D, and Florida has set up optional programs B, C, and D. Um, And Michigan has set up optional programs D, F, and G. So they all are setting up different optional categories of coverage. So it's very complex comparing across states. And then it's even complex within the state. Why is that? Well, I always tell people to think of Medicaid eligibility in your state. And now we can be specific about Tennessee, but we could be specific about any state. I'm not a Tennessee expert, um, which is that think about your state's Medicaid program not as a house that has a single door that everyone has to enter to get into the program. Think of it more like a small hotel, right? That has a lot of rooms and there are different rooms you're going into, and the rooms are the categories in the state. So for example, there's a category for children, there's a category for pregnant people, there's a category for people with disabilities. We'll talk about that more in a minute. There's a category for older adults. So there are all of these different categories, and the eligibility criteria are specific to that category. So somebody at a given income level might be eligible if they're a child, but not eligible if they're qualifying for the parent category. Somebody might be eligible if they're applying for the disability category, but not if they're applying for the pregnancy category. So it's not just one eligibility criteria, one income limit that controls whether you get into the program. Instead, it's like 30 doors. And depending on what program you're trying to get into, you're going to have different criteria, different income limits, right? And so, like to give a concrete example, the income limits for children tend to be quite high. So if there's a child with um, um, $1,400 of income per month in the family, that child is almost certainly going to be eligible, is certainly going to be eligible for Medicaid in every state. If there is a person with a disability that has $1,400 of income, now it's a maybe, depending on how the state has set up its categories, what categories there are. If we're talking about the category for parents, they're almost certainly not eligible because those income limits are very low. So your income limits are vary by what category you're going into. And so even within Tennessee, you can't say, what's the income limit for Medicaid? Because that depends. What program are you applying for? What are the eligibility criteria? Well, that depends. What room are you trying to get into? So then when we talk about disabilities, it gets even a little more complex because it turns out that this hotel doesn't have just one room for all people with any kind of um, disabling health condition. Instead, this hotel has lots of rooms for different types of disability categories. So let me talk through the major ones just so you kind of get a sense of this, but you could spend a lot more time on this. And I'm not like super expert on disability per se. So first of all states must cover anybody who qualifies for SSI. So that's your mandatory room in every state. Um, States can then choose at their option to increase that income limit. Some of them do, but definitely not all of them. So that's one room. Then we have this room, which is people who are qualifying because their states have chosen to provide institutional coverage or home and community-based coverage. And we'll talk a little bit more about home and community-based coverage in a second. Um, you have a program, and those programs are great because then they tend to have higher income limits, among other things. You can get a wider range of services and they have higher income limits. The standard category for disability, the income limits are actually very low in most states below the poverty level, in the median state below the poverty level. So you can actually be quite poor and still not qualify with in the basic disability category. So that home and community-based services or institutional category may have a higher income limit, and it may get you services that are not in the standard Medicaid benefits package. There is a category in most, maybe all states, for um, workers with a disability. So if you have a disability and you are working, you may qualify for a category with higher income limits. And so you may be able to get in through that door. And then we have this set of doors for people who have Medicare. Because one of the other things that Medicaid does is it is a backup coverage for people who have Medicare if those Medicare enrollees are low income. And so the way that works is it's in tiers. The highest income Medicaid people will qualify only for Part B premium payment, meaning Medicaid will pay their Medicare Part B premium for them, and they don't get anything else from Medicaid. So literally, Medicaid's just stepping in and paying that premium every month, which is a great help to those people. The tier that's a little more lower income, they will get help with all of their Medicare cost sharing, right? So Medicaid is not only going to step in and pay that Part B premium, but it's going to pay other costs that you have with your Medicare, such as your 20% cost sharing on a lot of physician visits, right? So that's even more helpful. And then the tier that's, lowest income, they are going to have Medicaid paying those Medicare costs for them and also providing them with a Medicaid benefit, which may give them additional services. So this group of people, dual eligibles who have both Medicare and Medicaid, they're qualifying for kind of different levels of Medicaid coverage. Some we call sort of, you'll hear people say sometimes like full benefit people who are getting the whole Medicaid benefit, and some who are only getting partial benefits. So incredible complexity there, as you can see in each of these different rooms that you're qualifying for the Medicaid program, and they're going to have different income limits. And that's why anybody who has a disability or has a child with a disability, when you're considering the Medicaid program, you really want to make sure you're getting assessed by an expert who is familiar with in your state what are all of the different categories with all of their different income limits and eligibility requirements. Because if you get screened for only one category, that might not be the one you're eligible for. And there may be another one that you are eligible for. Last thing I'll just say, I know this is a lot of eligibility information, but I know this is what confuses people, is around this word waivers, which you hear, home and community-based waivers. So let's just say for a second what that means. When people are trying to get home and community-based services, if you qualify for the standard Medicaid categories, there is some limited amount of home and community-based services that may be in those categories, but it's relatively limited. Depending on the state, it might be very limited. So it's not going to be super helpful to somebody who has any kind of high um, um, functional support needs. So states have the ability, the option to expand coverage for people with a wide range of disabilities and functional um, limitations to cover long-term care type services, home supports, all of the home and community-based services and supports people might need. And so states can set that up, making it a standard part of their Medicaid coverage options, which we call a state plan benefit. But many states historically have set this up through waivers. And waivers just means exceptions. It means an exceptional program, a special program the state is running. And the reason it's special is that normally a state cannot say, we're going to offer X service and we're only going to offer it to people with this type of disability. States, when they're offering services to people with disabilities, the default rule is they have to offer it to everybody. When they create a special waiver program, what they're saying is we're going to set up a special program, let's say, for people with a traumatic brain injury. And so we're going to create a special suite of services that is really relevant to that population. And we're not going to make it available to everybody who has any kind of disability in the state, right? So it's called a waiver program because the state is getting an exception to the normal rule that you have to provide the benefit for everyone, and the waiver is allowing them to target the benefit to a specific group. So waiver programs are optional programs states set up to target a special set of benefits to a special subset of recipients with some kind of disability. And the waiver will have like eligibility criteria tied to some type of disability. It might be DD specific, it might be traumatic brain injury, it might be just basic functional supports for people with disabilities. It could be states, and many states operate multiple um, of these waiver programs, each targeting a specific population. The great thing about when you qualify for one of these waiver programs is the income limits are higher, first of all, so more people can qualify. But second, it will come with a set of support services that is specially designed and may be superior or a better match for that individual than the other services. The bad news on waiver services is first, it's an optional program. So as we talk about Medicaid cuts, there's risk, and we'll get into that. And second, whereas in the normal Medicaid universe, right, say a standard program for people with disabilities, states are not allowed to restrict enrollment in any way. This is an entitlement program. If you have SSI, you get Medicaid, period. And that doesn't matter if there's 10 people in the state, 100 people in the state, 1,000 people in the state, 100,000 people in the state, doesn't matter the number, you always get Medicaid. When it comes to waiver programs, states have some flexibilities to set limits on how much they're going to spend on that program, how many people they're going to enroll in the program. And what that means is sometimes you will have a situation where there is a waiver program, but the waiver program only has 2,000 slots in the state. And so if you're person 2001, you're going to get put on the waiting list. And sometimes the number of slots is way inferior to the number of people who need the services. And so very quickly, the waiting list is like, twice as big as the program. And so the waiting list, ends up being a 6-year waiting list type of situation, which may defeat the purpose of the waiver in some circumstances.
Oh,
So super complicated, very hard for families to navigate. It's a place where families need a lot of support to understand how this world works because it's not intuitive.
I tell you what, Leo, that's partly what has me freaking out because we on a waiver program called Katie Beckett, and so obviously it doesn't take our income into consideration, but it does provide services that are needed up to a certain level, right? And with those cuts and that waiver being in that optional category, it just I just feel that that is at a super big risk. But I just want to kind of look at that just to perhaps summarize some. So the states, in terms of eligibility, there are some optional programs, there are some mandatory programs, but whether it's optional or mandatory, there are still very specific criteria that varies from state to state on how you can get through that door to access Medicaid. Um,
That's right. It varies not only state to state, but even within the state, depending on what the category is.
would it be okay for us to cover funding now, Leo, and how
Yeah,
the money flows through from federal to state level?
yeah. And unfortunately, the funding is also complicated. But let's start with the basic point, which is that states get federal matching dollars for state spending on healthcare services. So as the state spends state dollars, it gets a federal matching dollar. And those matching payments work based on this nerdy formula where the richer states are going to get less matching dollars, and the poorer states are going to get more matching dollars. So, for example, the poorest state right now is Mississippi. And for every dollar that Mississippi spends on Medicaid services, it actually draws a little over $3 in federal funding. So you can kind of think like Mississippi is kind of paying 25% of the cost in general because every time it spends a dollar, it gets $3 in federal funding. The richest states for every dollar they spend, they only get $1. So they're kind of paying like half the cost of their Medicaid births and everything else. And the average state, right, is closer to a 2-for-1 deal. So in your average state, the state will be spending about $1 and it'll be getting a little bit less than $2 federal. But, so that's about average. So that's sort of your normal Medicaid funding system. So you can already see that on average, states are when we talk about how the Medicaid gets paid for, states are paying somewhere between 25 and 50% of the bill. And the federal government is paying somewhere between 50 and 75% of the bill, usually closer to a 60-ish number, on average. So right out of the gates, you can see the federal government is financing most of the Medicaid services that Tennessee is providing, right? More than half. And that's true for just about every state. Now, um, in addition to that, there are some features of the program where they don't use that general standard matching rate. Instead, they use a higher special matching rate. And one of those areas where there's a special matching rate is the Medicaid expansion program, where here, for every dollar the state spends, the federal government kicks in $9. So the state is paying for 10% of Medicaid expansion. Now, Tennessee doesn't have a Medicaid expansion. So this is why we say the 10 states that haven't expanded Medicaid
Right
are
there.
leaving tons of money on the table. Because if they just spent $1 on the health care of these Tennesseans, they would get $9 in federal matching funds. And of course, you do pay federal taxes, right? So you're financing the $9 that are happening in Michigan or in Arizona or in North Carolina, but you are not taking the deal to get the $9 for yourself, right? So Medicaid, not expanding Medicaid is a bad deal for Tennessee. Those federal matching dollars that the states are getting for Medicaid, you just can't overstate how critical those are for states and their state budgets, right? The first point is, right, these matching rates that the federal government is paying 50 to 75% of the cost means that states have enough money to actually meet the needs of the enrollees in their state, right? Meet the needs of people with disabilities in Tennessee or any other state. States have healthcare inflation, right, driving up costs. Uh, they have recessions where their state revenue goes down and they're going to struggle to pay for the support services people need. States have natural disasters, right? We just had hurricane damage in North Carolina. That's going to jack up the state's costs. We of course have pandemics, right? Um, and so the I mean, everyone obviously understands the COVID pandemic, but HIV/AIDS has been going on for 40 years now. So and those services are really expensive, and they suddenly fall in the state's lap. And the open-ended Medicaid matching rate, guaranteeing the state that it's going to get those federal matching dollars, is what allows the state to survive all of these increasing costs and these rough times because the federal government never turns its back on the state. The state is always eligible for this money. And just to understand um, what it means for states, let's put together two ideas. So bear with me for a second, but it's really important that your listeners understand this. And I know you all care about education for your kids, so I want you to see the connection here. If you look at the federal dollars coming into states, so where states are getting their federal dollars, over half of the federal dollars are coming for Medicaid, 56% nationally, right? If you look at education, it's only 13% of the dollars coming in. So 4 times more money is coming into states for Medicaid than is for education, right? So that's a lot of Medicaid dollars. But here's the amazing thing. If you look at what states are spending their state dollars on, so if you look at Tennessee's budget and what Tennessee is actually spending its money on, you'll see a flip, an inversion. States on average are spending 43% of their spending on education, and Medicaid is only 19%. So states are spending much more of their own money on education. And so the story here, when you put that together, is that the generous federal funding for Medicaid is solving states' healthcare problems, but they're also allowing the state to turn around and pile more money into education, right? They're getting 4 times as much federal dollars for education, which is allowing the state to say, hey, you know what? We don't have to spend all of our state money on healthcare. We can pile state dollars into education, right? So the Medicaid dollars are 56% of the federal dollars coming in. And if you cut that out, it creates a huge problem for all of the other state priorities where the states are putting in their money. My like simple example for people is like, imagine if mommy is paying for your healthcare costs, you can spend your money to pay your college tuition. If mom stops paying your healthcare bill, you can't pay your college tuition anymore, right? And that's the effect the states have because these Medicaid dollars are coming in and they're um, take solving this healthcare problem because the births are going to happen. People with disabilities are going to need support services. Older adults are going to need healthcare services, right? That's going to happen. And if you don't get federal money for that, then the state can't spend its state dollars on education and other priorities.
I know this might sound like a simple question, but why on earth would a state not accept or initiate the Medicaid waiver? I mean,
So
what's the,
specifically Medicaid waivers.
I'm sorry,
So
Medicaid expansion, excuse
yeah,
me.
yeah. So the Medicaid expansion, I think it became a political football, and you have a lot of states that aren't sort of state leaders that aren't sort of evaluating, okay, what is actually in the best interest of Tennessee? We could get 90% of the cost of healthcare for adults in Tennessee who are low income. A lot of these people are parents. A lot of these people, as we'll talk about, are people with disabilities. We could get 90% of their healthcare covered if we take this option. That turns out is really good for state infrastructure, and I'll talk about that in a second, but it's really important for the state's hospitals to stay open. So this is a win-win for the state of Tennessee. The only thing Tennessee has to do is pay the 10%. And here's the most incredible thing about this. Many of the states doing this, they're not even paying that 10% out of their own general fund. They are um, implementing a tax on tobacco to pay for the 10%. They are putting a tax on hospitals to pay for the 10%. And the hospitals in those states are actually supportive of the tax because when that tax happens, the 10% gets raised, the state expands Medicaid, and all the people who are showing up uninsured at the ER now have coverage, right? So the hospital actually is kind of getting its money back. So they kick money into the tax, which gets them. So you literally have um, there are hospitals in Tennessee that would I think give the state the 10% because this is what they're doing in other states. So the state is not actually even going to have to pay the minimal 10% of the cost, right? So it's just a bad policy decision for the state. And it's because of I think political football. Um, but this point about what it means, the other thing so we talked about why it's important to the state budget, but why is it important for rural America, right? And of course, in the Southeast, you have big rural pockets where the economies are not where we want them, where people don't have enough opportunities. Um, and a lot of people are lower income. Um, and what's so challenging is there's a lot of people who are low income, but there aren't that many people total, right? And so how do you keep a hospital open out in rural America? And the answer is Medicaid. Medicaid is providing health insurance to the people living in that rural community. A higher percentage of people in rural communities are getting health care through Medicaid, right? And so that's how those rural hospitals are getting paid. And Medicaid is actually also making extra payments to those hospitals to keep them open. So if you cut Medicaid, you're cutting the financing that rural hospitals depend on. And rural hospitals, it turns out, are at huge risk. Many of them are actually running at a loss. So if at current with current funding, so if you take away current funding, they're going to run at a deeper loss. And we do have a problem in this country that I don't think people understand, that rural hospitals actually close. And so you have these rural communities that lose their rural hospital. And we're talking about somebody who may have a 1.5 hour drive to their local hospital. And when that hospital closes, the next closest one is now a 4 hour drive, right? Just really, really problematic system issues. And when that rural hospital closes, that's not just a problem for the Medicaid enrollees in that community. It's a problem for anybody in that community with any insurance because it doesn't matter what insurance you have. You can't go to the hospital after it closed.
I mean, it impacts employers, it impacts business. It's just not, I mean, it's just not healthcare. I mean, these it's a wide ranging outflow. But I want to get to um, the Medicaid cutbacks that are being proposed right now. We know it passed the Senate and is now moved on to the House. What does this mean for us? What can listeners do to speak to their representatives to know what Medicaid means to them and their families, Leo?
Right. So sadly, Congress is considering gigantic, these are historic cuts to Medicaid. They're doing it in a rush without really even explaining what they're doing. We know the House is going to do $880 billion of cuts. It could be more. Um, we just don't know because they're rushing so fast and not explaining what they're doing. It's like this situation is like if you walked into the hair salon and while you were walking through the door, there was already somebody with scissors, cutting big chunks out of your hair. Um, they're rushing to make big cuts, and there's been no discussion of the plan. And there actually is no plan. They're just rushing forward, and it's not a trim, right? They're going for the buzz cut here. This is a big cut. Where we are is that the House is rushing to develop and finalize um, proposed cuts in the coming week or weeks. Um, and they are sort of intentionally not talking about exactly what is in their plan. Um, and that's some combination of that they really don't know what it is, but they also know that whatever it is, it's not going to be popular. So they don't even exactly know what they want to cut yet, but they know they want to make $880 billion of cuts. The Senate is likely not to develop its own policies, but instead just kind of tweak the ones that the House proposes, we think. Um, the House Speaker Johnson in the House, his original timeline was to have it all done by Memorial Day, just a month from now. But it looks like the House may be aiming to have their work done by Memorial Day, and then maybe the Senate would do their part in June to have some kind of deal for Trump to sign by July 4th. So we're literally 2 months away, maybe less, from really historic and devastating cuts to this program. Now, it's really important to know that there have been past efforts to cut this program. And we saw that in 2017. And families with disabilities and the disability community writ large stepped in and saved Medicaid, literally for everyone. I work on Medicaid for all populations. So I'm worried about kids. I'm worried about pregnant people. I'm worried about seniors. I'm worried about low-income parents. Worried about working families. I'm worried about people with disabilities. But it was the disability community responding to what these cuts would mean for people with disabilities when they were proposed in 2017 that won the day. And so I just want to acknowledge that. I want to thank you and your listeners and your community for the way that you stepped in and saved everyone, Medicaid for everyone in 2017. And I'm hoping your networks will mobilize and activate to educate everyone in their state, all the stakeholders in their state, because this is true for Tennessee and it's true for every state. So your listeners that are not in Tennessee, this is true for your state wherever you are. Um, these are giant cuts to Medicaid. It would make the program totally unsustainable for states. Um, so how do they pay for the births? How do they pay for the home and community-based services? Um, it's really, really problematic. We have a set of cuts that are just like financial cuts, and then there are a lot of bad policies, like the cut to Medicaid expansion, like work requirements that we could talk about more specifically.
Leo, I would like to ask about, we talked about, are you good with the way we covered Medicaid expansion? Are you good with that?
Yeah, I am. What I do want just people to really take home is, and this is important because there is misinformation being peddled to people with disabilities right now. And so here's the lie. The lie is don't worry about Medicaid expansion because that is for quote unquote able-bodied people. That's what they say. And there are actually people saying if we cut Medicaid expansion, that will help people with disabilities because it means there will be less funding going to able-bodied people and more funding going to people with disabilities. The 90% match rate for Medicaid expansion is unfair because it discriminates against people with disabilities. They're saying all kinds of lies to try and confuse the disability community and make the disability community think they don't really have a stake in Medicaid expansion. Um, the truth is that there are tons of people with disabilities in Medicaid expansions in the 40 states that have done a Medicaid expansion. Um, and the reason for that is we said there is a mandatory category for SSI, but SSI standards are actually quite strict. And there are tons of people with disabling conditions who do not meet that standard. Um, People with disabilities, people with chronic health conditions, et cetera. The second reason is remember what we said. Well, the SSI income limits are super low. They're below the poverty level. There are people who literally live in poverty who are too rich for the SSI income thresholds. But the Medicaid expansion income threshold goes quite a bit above the poverty level. So there are a whole lot of people who do have the disability, the SSI related disability standard, but they actually are over the income limit. And without Medicaid expansion, they don't get into any room, right? We talked about the rooms in the hotel, right? If the hotel doesn't have a Medicaid expansion room, that person doesn't have a room to get into. So the takeaway is cuts to Medicaid expansion are a direct attack on people with disabilities. Um, and I'm saying this because they seem to be gravitating towards Medicaid expansion as the piggy bank for them to be able to pay that $880 billion cut.
Another misnomer, or, we hear of this term, fraud, waste, and abuse of public funds, of federally funded programs. Can you maybe expand on that, Leo? Or, just what does this mean for the average person who hears this term being churned out all the time, fraud, waste, and abuse?
Yeah. So the first thing to understand is that everybody would like this program to work more efficiently. My team that does research and work on Medicaid policy, we make a lot of suggestions that are precisely about ways to make Medicaid work more effectively. Um, there is not $880 billion of waste in Medicaid, right? This is like somebody coming to your household and saying, you're going to need to cut $60,000 of money out of your household because we think it needs to work more efficiently, right? Like I'm sure all of us could do a better job at clipping coupons and saving some money at the supermarket. And that might get you $100 a month, but it's not going to get you $60,000, right? So the first point is that $880 billion dollars is hundreds of times more than the amount of waste there is to trim in this program. You know, um, this is an 8 ounce steak, and they're asking you to trim 20 pounds of fat off of it. Like it's just not there. So this their numbers are totally off. Second point is their policies are totally off. If you look at their policies, the three biggest policies that account for 80% of their potential cuts, all of them are just flat financing cuts. They're just reducing the amount of funding available to states, right? If right now Tennessee gets $2 for every Medicaid, $2 federal for every Medicaid dollar it spends, and you said tomorrow, all right, Tennessee, from now on, you're only going to get $1 for every state dollar you spend. You have just cut the state's funding in half. So that is going to reduce the spending. But have you done anything about fraud? No, you've just cut the budget. Well, their top three cuts are all about just cutting the budget. And if you just look at that, you just know this is not at all about waste. What would you do if you cared about waste? You would look at the pieces of the program, the specific pieces of the program that could be run better. You would develop policy to run those pieces better, and you would develop the oversight mechanisms to make sure that they're run better. And if you did that, you might save $1 billion. You might save $2 billion, but you would never get to $880 billion. So their financial target is not credible as an attempt to address waste, and their solutions literally have nothing to do with waste. Uh, my example that I like use to just explain this to people is, let's say your state has 50 elementary schools, and you suspect that somewhere in your state there's some inefficiency because there is a principal who is, wasting money and and buying four expensive unnecessary things for the school. I don't know what that would be. I don't know, like flat screen TVs. They're buying four expensive flat screen TVs. That's what you suspect is happening. Would your solution to that scenario be, we're just going to go and cut in half the budget for all 50 schools in the state? That's how we're going to solve the problem. No, because the 49 schools that aren't doing that just got their budget cut by whatever, 25% or 50%. And the one school where that waste is going on, if you cut the budget by 50%, instead of buying four flat screen TVs, that principal is going to buy two flat screen TVs. You've just cut the amount of his wastefulness in half, but you haven't actually addressed the waste, right? What you would do is have some policy targeting the waste and have some way to monitor it. Their proposal to just chop the program is not actually addressing inefficiency in the program at all. And we do have a lot of suggestions about how you could address inefficiency. They don't engage in those ideas. They're just trying to cut the program. That's why this is so important. And one thing, just so people with disabilities are aware of this, one thing that you will hear them say time and again, they'll come up with some policy idea, and they'll say, "Oh, but people with disabilities, don't worry about it. We're exempting people from disabilities from this cut." Well, first of all, if it's a giant chop to the state's budget, it's gonna impact everybody, right? There's no way to single it out. But the other thing is just anyone with disabilities who works with disabilities community should understand that it's obviously not true because of how diverse the community of people with disabilities is, right? And I try and explain this to people all the time, and I say to them, well, you could have somebody who is an Olympic decathlete who has a mental health disability, standing next to, Stephen Hawking, who is twice as smart as all of us combined, next to 10 other people with disabilities, and they would look all so different. And it just happens that in our universe we lump them all together as a people with disabilities, right? But they're all so diverse. And so how would you possibly, right, find a way to insulate all of these different types of people from whatever this cut is, right? Not possible. Um, so they're just this all of these cuts are really big. They're not targeting waste, and they're going to hurt people with disabilities. And maybe we should talk more about why they hurt people with disabilities.
The other part to this and with those proposed cuts is how does it affect like healthcare providers? Because, uh, I mean, each year or annually, that physician schedule, fee schedule just seems to, I mean, it's a continuous fight of a 3% cuts, 5% cuts. I mean, just not keeping up um, with the cost of living or inflation. What are the potential ramifications for those healthcare providers? I know staying for business for me is one, but can you speak more to that?
Yeah. So if we just think about where we are right now, at current funding, provider rates are too low, and they struggle to keep up with what the actual market rates are. So then imagine if the federal government massively cuts the amount of money that Tennessee is getting in federal dollars. And now Tennessee has a huge hole in its budget. And I'm using Tennessee as the example, but we could be talking about any state. They have a huge hole in their budget that they need to fill. What do they do to fill that budget? Well, they have three options. The first option is to cut eligibility. Less people get Medicaid. The second option is to cut services. The people in Medicaid get less services. And the third option is to cut the rates for the Medicaid services they provide. So when that federal cut happens, the state is going to need to make up money. And the way the state is going to make up money is huge cuts to provider rates. Um, and so it's going to have the reverse effect of what you would want, which is to see the state strengthen those provider rates, both to keep the providers open, but also for access, right? When Medicaid rates are super low, it becomes really hard to find a provider. And that might be finding a specialist for your child's healthcare needs. It might be finding home attendants, right? We see this in Medicaid all the time where somebody actually has prescribed hours of some kind of support service, but can't fill the hours because there's nobody willing to do the job at the abysmal rate that's being paid for the service in the state's Medicaid program. So this is exactly contrary to what we would want. And so there's a threat to provider rates. And then there's also a threat to the actual coverage for people with disabilities. Remember what we said earlier. Most of the programming we care about for people with disabilities is optional. Um, these home and community-based services, they're optional. So when the state needs to make up huge numbers, the only thing it can do is look at the optional services. And then within the universe of optional services, right, um, these services are quite expensive. So a state that needs to make up money, right, it's kind of like the bullseye just starts to fall quite heavily on the services that people with disabilities need to make up. And I know many of you may have been involved in sort of your internal state budget fights over the years in Medicaid. And I just want you all to understand your normal state Medicaid budget fight is a fight about the state having to make up 0.25% of its Medicaid budget. And so it implements, these cost-cutting measures that are painful, um, but they are not existential, right? They're 0.25% percentage point. We're talking here about a reduction to the state, I don't know, 15% of their Medicaid money, 20% of their Medicaid money. So when you think about those painful cuts in the context of a quarter of a percentage point, when we're talking about 15%, right, we are not talking about small cuts at the margins. We're not saying somebody who has 36 hours of support, they're at risk of only having 34 hours of support, right? We're saying that programs might get obliterated, services might get obliterated. Like somebody would have to really take a hatchet to this to cut that, right? It's like me telling you your household budget is going to have to reduce, right, $4,000 a month of spending. Like if I tell you that, you immediately are like, okay, well that would we would have to change the way we do everything around here, right? Like this isn't just like being a little more frugal at the grocery store. So the risks to people with disabilities are really high if we get ourselves in this environment where the state has that kind of pressure to make cuts.
Leo, as we round up, is there anything that you talked about 2017, right? And how the disability community kind of came forward and stepped up and were able to tell their story and save Medicaid. What can we do right now? What would be the call to action to ensure that we protect Medicaid?
Well, I do think it's important for everybody to be engaged in educating their community and their networks about what you heard on this podcast, what you're reading in the news, so people understand the imminence and the scope of the threat that's in front of them, because this is happening right now, and it is gigantic. And I think there's so much in the news, there's so much in the headlines that it's overwhelming, and it's hard for people to keep up with out in your community, and so you need to help them. And the second thing is, and this you mentioned, that is so important, is telling your story, helping people understand this abstract idea. Oh, we're going to reduce the Medicaid expansion matching rate from 90% to 60%, right? Like, what the hell does that mean to anybody? It doesn't mean anything to anybody. When you tell them, here's what this could mean for my child, right? Here's who my child is, and here's what this could mean for them. That totally changes the conversation. It turns into a conversation that people really, really remember. Um, and I always tell this to families. If someone like me goes into an office and tells somebody facts and figures, when I walk out of the office, they will not remember my visit. If somebody, see, if a family goes in and tells the story of their child, or tells the story of their about their mother, or tells the story about their significant other, whoever it is in the family, um, their story will be remembered. They will be remembered, and it will cause people, when they hear this abstract idea, to connect with the emotional feeling about what this impact is on people. And that is irreplaceable. That is the gold that moves people to make decisions.
I don't even know how to thank you for your time, Leo. You I guess a simple thank you will have to suffice for now, but the information that you brought to us is here to educate and empower us to carry this message forward into our communities. I will work on getting a transcript of this done as well and placing on our website. So for parents or listeners that would like to go back to kind of review, they will have this as well. Um, Thank you so much for your time, Leo.
Thank you so much for having me, Marsh, and thank you to you and your community for all the work you do. So happy to support it in any way we can.
You have a great day, okay?
You too. Bye bye.